So now that we had seen about the first hallmark, which was proto-oncogenes, now let's move on to the second hallmark of neoplasia, which is insensitivity to the growth inhibitory signals. So meaning the tumor cells are not going to respond to the inhibitory signals. They are just going on proliferating. Okay. So under this, we have again certain subheadings. So all of these genes which we study here are going to be tumor suppressor genes. So firstly, will see inhibitors to the mitogenic signaling pathways. Basically, they are inhibitors to the signal transducing proteins. So the first one is NF1, which is also called as, this gene is going to encode for the protein which is neurofibromin, and it is going to be present on chromosome 17q. Okay, so this one we had already seen under the GTPase activating protein, gap proteins, remember, during which is going to inhibit the RAS activation. So that was a tumor suppressor I mentioned there. So this NF1, which is present on chromosome 17q, can be mutated and it can lead to certain tumors like neural tumors, basically malignant peripheral nerve sheath tumor, which is we call it as MPNST, then neuroblastomas as well. Then NF2 gene, which is again called as Merlin gene, which is present on chromosome 22q, and both this NF1 and NF2 are going to be related with the neurofibromatosis syndrome. And here this NF2 is associated with schwannomas and meningiomas. Now the third gene will be the P10 gene. So it is going to be present on chromosome 10. So 10 for 10. Okay. So P10 mutation is going to be present in syndromic associations like Cowden syndrome. So there again you have DEN, right? So DEN is also resembling like 10. So P10, Cowden syndrome, chromosome 10. And here it is going to cause the breast carcinoma, endocrine carcinoma, endometrial carcinoma, thyroid carcinomas and other GI cancers as well. Then the next one under this will be the APC gene, which is present on chromosome 5q. So this is going to be mutated in the familial adenomatous polyposis, which was an autosomal dominant disorder. So in familial adenomatous polyposis, you are going to have more than or equal to 100 intestinal polyps, and they have a very high risk of transforming into colon cancer. So these patients develop colon cancer at a very young age, and it is 100% risk for colon cancer. Okay, so this APC gene is a tumor suppressor gene, and this is going to be called as the gatekeeper of colonic neoplasia. So this is the main gene. If this gene is going to be mutated, it is going to lead to colonic neoplasms. So this APC gene is associated with the beta-catenin pathway also. So this APC is going to be mutated. This beta-catenin is again a main part of the colonic neoplasms. So either through the familial adenomatous polyposis, this gene is going to be mutated, or in the normal colonic sporadic cancers also, this APC is mutated, leading to beta-catenin pathway dysregulation. So this is going to result in mainly colon cancer. Other than that, pancreatic cancers and stomach cancers can also result by this mutation. So this is going to be called as the gatekeeper of colonic neoplasia. So the first tumor suppressor gene is over. The next one will be the inhibitors of cell cycle progression. So we saw cyclin and cyclin dependent kinases which help in promoting the cell cycle. So those were the proto-oncogenes. While those things which are going to inhibit the cell cycle, like the RB gene. So retinoblastoma, we saw it is going to be the checkpoint in the G1S phase, remember. So this RB gene is going to be an tumor suppressor gene. So retinoblastoma gene, it can be mutated mainly in as the name suggests, it is going to be mutated in retinoblastoma. Other than that, osteosarcomas, breast cancers and many other tumors as well. And this was the first tumor suppressor gene to be identified, and it is going to be called as the governor of the genome. So gatekeeper of colonic neoplasia was APC, governor of the genome is going to be RB gene, and the policeman of the genome is going to be the P53. Okay, we have various other names for P53 also. Let's see that later. So governor of the genome is going to be RB gene, and this RB gene is going to be present on chromosome 13q14. So there is something called as a Knudson's two-hit hypothesis. So Knudson's two-hit hypothesis means the RB gene being a tumor suppressor gene, both of the genes must be deleted for the disease to develop. So Knudsen's hypothesis tells that it is going to be of two types. Retinoblastoma can occur in two different pathways. One is the familial pathway, which is the hereditary pathway, and another one is the sporadic pathway. So in the familial pathway, Knudsen's hypothesis tells that the first hit must happen before birth. Okay, one of the alleles of this retinoblastoma is going to be deleted before the birth itself. But the second hit, the proper allele, the second allele is going to be deleted post birth. Okay, so first hit before birth and second hit after birth in familial retinoblastoma syndrome. And here, because both the retinoblastoma alleles are being going to have a loss of function, it is also called as loss of heterozygosity. Basically, it is behaving like a homozygous condition, but still we call it as a loss of heterozygosity. So in familial retinoblastoma syndrome, we are going to have bilateral retinoblastoma. So both the eyes, the child is going to have retinoblastoma. Along with that, the child is also going to have an increased risk of developing osteosarcoma and pineoblastoma. And when there is a bilateral retinoblastoma along with the pineoblastoma, it is going to appear like a trilateral triangle. So it is going to be called as a trilateral retinoblastoma. So trilateral retinoblastoma is nothing but bilateral retinoblastoma plus pineoblastoma. Okay. This is for familial. So under sporadic, which is non-hereditary, as such, the sporadic retinoblastoma is going to be more common than the familial. And here, both the hits of the retinoblastoma allele is going to happen after birth only. Okay, in familial, it was first was before birth and second was after birth. But in sporadic, both the hits are going to be after birth. Okay, so that is the difference between this familial and the sporadic. So if you see microscopically, retinoblastoma is going to have two characteristic findings, which is the rosetting. So the rosettes are nothing but flexner ventosternal rosettes and Homer-Wright rosettes. So flexner ventosternal rosettes are going to be called as true rosettes because this is forming a rosette. So this is looking like a rosette. This is a rosette, this is a rosette. So everything is a rosette. But in the center, if you see, it is having an empty hole. So empty lumen is one in which we call it as a true rosette. So anywhere, any rosette which has an empty lumen with no contents inside it, it is going to be called as a true rosette. So examples of true rosettes are flexner ventosternal rosette, which is found in retinoblastoma. Other than that, we have true type of true rosettes in ependymoma, and also we also have central neurocytomas, which are again a brain tumor, which again have true rosettes. Okay. Homer-Wright rosette is a pseudo rosette because here this is a rosette, here this is a rosette. So everything of this is going to form this rosette. So in the center of the rosette, if you see, there is going to be some pinkish material. So this pinkish material is nothing but the neuropil. So the lumen is not free, it is having some content inside it. So Homer-Wright rosette is a pseudo rosette. So examples of pseudo rosette are Homer-Wright rosette, and then we also have ependymal pseudo rosette. So in pseudo rosette and ependymoma, we are going to have a blood vessel in the center surrounding which the tumor cells are present, like a petal arrangement. So that is what is called as a rosette, like a rose. Okay, so we have many other pseudo rosettes as well, but Homer-Wright pseudo rosettes are not specific for retinoblastoma. You can see it in other conditions as well, which is neuroblastoma, medulloblastomas, Ewing sarcomas, and also in this retinoblastomas. Okay. So Homer-Wright pseudo rosette is not specific for retinoblastoma. So as such, a blastoma, retinoblastoma is a blastoma kind of thing, right? So you are going to have undifferentiated kind of cells. So these undifferentiated cells can either form in sheets or it can form these rosettes. So the second type of tumor suppressor, which was the RB gene, is over. The third type of tumor suppressor is inhibitors of metabolism and angiogenesis. So if you want to remember the tumor suppressor genes, you can remember it this way. So either it is going to oppose the oncogenes, the proto-oncogenes, or it is going to oppose the hallmarks of neoplasia. So in order for a malignant cell to invade and grow, it needs to acquire the hallmarks of malignancy, right? So these tumor suppressors are going to inhibit each of this hallmark. So if you remember it that way, it is going to be easy. So under hallmarks, we discussed for the tumor cell to grow, it needs to undergo angiogenesis, right? So this tumor suppressors are going to inhibit the metabolism and also angiogenesis so that the tumor cell growth can be prevented. So the first tumor suppressor in that category will be VHL. So VHL is von Hippel-Lindau, which is present on chromosome 3p. So this is going to be deleted in the VHL syndrome, right? So VHL syndrome, it is going to be prone for developing multiple cancers. The commonest one is the clear cell RCC. Bilateral clear cell RCC will be there. Along with that, they are going to have cerebellar hemangioblastoma. So cerebellar hemangioblastoma is a grade 1 tumor in the cerebellum. So other than that, we are also going to have retinal angiomas, right? So this is for VHL. So as such, what is the function of this VHL gene is that when this VHL gene is there, it is going to inhibit the hypoxia inducing factor. So when hypoxia inducing factor is being inhibited, the VEGF, which is the vascular endothelial growth factor, cannot come into play, and without VEGF, angiogenesis is not going to happen. So VHL is actually inhibiting the angiogenesis. But when this tumor suppressor VHL is being deleted, as in VHL syndrome, this angiogenesis is going to happen. Okay, so because of this angiogenesis only, if you see, the tumors related to VHL syndrome have some angiogenic components. So hemangioblastoma, so angio is there. Retinal angioma, so here again blood vessel proliferation is going to be there. Understood? So the second gene under this inhibitors of metabolism and angiogenesis is the STK11. So STK11 we will be seeing it again in the GI tract also. So this STK11 is involved in the metabolism, some nutritional pathway. So this tumor suppressor gene is going to be mutated and it is going to result in a Peutz-Jeghers syndrome. So Peutz-Jeghers syndrome is going to result in formation of colonic polyps. Along with that, the patients will also develop pigmentation around the anogenital region and also around the mouth. Okay, so perioral and the perianal region, you are going to have hyperpigmentation. Apart from that, they are going to have multiple colonic polyps as well. Okay, and they are at risk of developing GI cancers. So the next tumor suppressor gene category will be the inhibitors of invasion and metastasis. So tumor needs to enter and locally invade the tissues and then undergo metastasis. So this is going to be inhibited by tumor suppressor genes like cadherin. So it is going to, CDH1 is going to encode for a protein called as E-cadherin, which is present on chromosome 11. So this E-cadherin protein is, it is usually a cell-cell addition molecule. So normally these two cells, every cell is going to be attached with one another, right? Because of the presence of these cell addition molecules. So that is why they are staying in place. But when this E-cadherin is being mutated, the cell addition is being lost. So the cells can separate from one another and this singly separated cell can undergo invasion. So for metastasis to happen, the first step is to separate the cells from one another. So when E-cadherin is lost, it is going to lead to certain cancers, especially lobular breast cancer, lobular breast carcinoma, and also stomach carcinoma, which is a variant of stomach carcinoma, which we call it as linitis plastica. That is the diffuse type of stomach adenocarcinoma, in which you are going to have, both of these tumors is going to have singly scattered cells. So the tumor cells are not going to be coming in sheets. They are going to either form a linear pattern or singly discohesive cells, which have a characteristic signet ring morphology. So the next category of tumor suppressor genes will be the DNA repair factors. So normally DNA repair is there is going to be some mistake during cell cycle proliferation. So that mistake is going to be proofread and corrected by the DNA repair genes. But when these DNA repair genes are mutated, they are going to result in cancer. So the DNA repair genes can rightfully be called as tumor suppressor genes, right? So what are the tumor suppressor DNA repair genes? So first one, we will have the BRCA1 and the BRCA2. So BRCA1 is going to be present on chromosome 17, while BRCA2 is going to be present on chromosome 13. So this BRCA1 is going to, these BRCA1 and BRCA2, they are going to be causative for the syndrome called as hereditary breast ovarian syndrome. So breast ovarian carcinomas you are going to have, and especially in BRCA2, it is going to be male breast cancer. So both male and female can be there, but male breast cancer is usually associated with the BRCA2. Okay. Other than that, both the cancers are going to have colonic and pancreatic cancer risk as well, apart from the breast and ovary. In BRCA2, it is also going to have a prostatic adenocarcinoma. So, male for male. So, male breast cancer and male prostate. So, prostate and male breast cancer along with colonic and pancreatic cancer risk is there in BRCA2, while BRCA1, if it is mutated, it is going to result in breast, ovarian, colon and pancreatic cancer. So, female. Then the third DNA repair gene is going to be the MMR gene. So the MMR genes are nothing but mismatch repair genes. So we'll be seeing that again. So the mismatch repair genes are, these are the MLH1, MSH2, then MSH6, PMS1 and PMS2. So these five are going to be called as the MMR genes. These are going to be mutated or deleted and resulting in a syndrome called as the Lynch syndrome. So Lynch syndrome is also called as HNPCC syndrome, which is hereditary non-polyposis colon cancer. So, non-polyposis meaning these tumors are not going to have polyp risk, but directly they are going to form colon cancer. Apart from colon cancer, Lynch syndrome is also prone for developing colonic cancers, endometrial cancers, and also ovarian cancers. Okay, Lynch syndrome is for CEO. So, CEO for Lynch syndrome, MLH1, MSH2, MSH6, PMS1 and PMS2. Okay. So, the next category of tumor suppressor is going to be the enablers of genomic stability. So, the main thing which is going to protect the genome is the P53 gene. So, P53 gene is going to be P53 is the protein, TP53 is the gene which is present on chromosome 17p. And if they ask the most common gene mutated in human cancers, it is going to be TP53, while the most common oncogene which is mutated in human cancers will be the RAS gene. Okay. So, look at the question carefully. This T53 gene is going to be mutated and it is going to result in an autosomal dominant disorder called as the Li-Fraumeni syndrome. So, in Li-Fraumeni syndrome, that is going to, being an autosomal dominant disorder, every generation is going to be affected and they are going to present with multiple cancers. So, not necessarily the same cancer is going to present in the entire family. Different cancers they can present with. Especially, they are prone for developing CNS tumors like gliomas, then glioblastomas. Apart from that, breast cancers, then osteosarcomas. So, many sarcomas will also be there. Then leukemias, so blood cancers. So, all of these cancers are more prone in the Li-Fraumeni syndrome. So, I already mentioned the governor of the genome was RB gene, while the guardian of the genome, the molecular policeman or gatekeeper of the genome is going to be the TP53. If they ask gatekeeper of the colonic neoplasia, it is APC. Gatekeeper of the genome is going to be the TP53. So, except for governor, all the names are going to be given for TP53. Okay. So, how does this P53 actually protect the genome? So, any insult or injury to the DNA like UV radiation or any chemical damage or some kind of damage, radiotherapy. So, all of this is going to cause the activation of the P53. So, P53 was actually causing the checkpoint in the G2M phase of the cell cycle, remember? And that phase was the most radiosensitive stage. So, this is the reason why P53 is being activated with the radiations like infrared rays, UV rays, any radiation therapy. So, all of this is going to activate the P53. So, once P53 is activated, it is going to activate certain other things. So, firstly, it is going to activate P21. So, where else did we read P21? It was a cyclin-dependent kinase inhibitor belonging to the CYP family. So, CYP family was inhibiting all kinds of cyclin-dependent kinases. Remember? So, in that I had mentioned P21 is going to be regulated by P53. So, what happens is when P53 is getting activated, it is going to in turn activate this P21 and this P21 is going to inhibit the cyclin-dependent kinases. When cyclin-dependent kinases are going to be inhibited, so what will happen? It is going to cause cell cycle arrest. So, cell cycle is arrested so that further proliferation is not going to happen. So, the cell cycle is going to be arrested. Nextly, the P53 is going to activate two other proteins called as GAD45 and also other microRNAs and non-coding RNAs like microRNA 34 and long non-coding RNA. So, these are going to be activated and they will result in the DNA repair. So, cell cycle is arrested. So it is giving time for repair. So first it will try to arrest the cycle, and then it will take the give the time for repair by activating this GAD45 and the microRNA and long non-coding RNA. So once repair is not possible, that they are telling that it is not possible to repair this defect, what will happen? The p53 is next going to activate the pro-apoptotic proteins like BAX and PUMA. So when BAX and PUMA is activated, it is going to result in apoptosis of the cell. So no longer it is going to be salvageable. So p53 will give the command to kill that cell. Okay, so this is how p53 is actually protecting the genomic stability. So once the p53, which is the master regulator, it has helped in multiple areas, right? It is even going to have a checkpoint in the angiogenesis and nutrition as well. Okay, so every step this p53 is having a role. This master regulator is gone. So when p53 is being mutated, all the things are going to go haywire, and that is why cancers are being resulting, and that is the reason why in Limb-Romney syndrome there is going to be multiple cancers. So p53 we saw, and then the p53 is going to belong to a family wherein it is associated with p63 and p73 as well. So the p63 is going to have the squamous differentiation. So p63 is going to be expressed in wherever cells are having a squamous differentiation. So the marker for squamous differentiation is actually p63 and p40. Okay. So if you are putting immunohistochemistry to prove a squamous cell origin, you can use either of p63 or p40. Okay. Then coming to p73. So p73 is it is going to be again resulting in apoptosis, but here the apoptosis of the cancer cells following chemotherapy. So once chemotherapy is given, I already mentioned, apoptosis is going to be the major cause of this tumor cell death more than necrosis, and this apoptosis is going to be mainly mediated by this p73. Okay. So when we are discussing this p53 and RB, there is one thing I need to mention. So we all know about human papillomavirus HPV, which is a main causative factor for the cervical cancer. So more than 90% of the cervical cancers are going to be associated with HPV. So this HPV is going to have two proteins, which is E6 protein and E7 protein. So this E6 and E7 proteins are actually going to damage the RB and the p53 gene, and thus it is going to lead to the cancer. So this E6 protein is actually going to inactivate the p53, while E7 protein is going to inactivate the RB protein. So both the cell cycle checkpoints are gone. So cell cycle is going to progress, resulting in cellular proliferation and resulting in mutations and cancer. Okay. So how do you remember this? E6, it is a multiple of 3. So p53 also there is a 3. So this is E6 for p53, while E7 is going to be for RB. Okay.